Now, some patients are described as carbon dioxide retainers. So let's think about what is going on in this situation. But first of all, let's think about the normal physiology to understand this. In you, ventilatory effort, if you're healthy, ventilatory effort is stimulated by increased levels of carbon dioxide and reduced levels of oxygen. So if the levels of carbon dioxide in your blood increase, for example during exercise, that's detected by the medulla oblongata, by the respiratory centre in the brainstem in the medulla. And if the levels of carbon dioxide increase in the blood, that massively stimulates ventilatory effort, and you'll start puffing and panting to try and get rid of the carbon dioxide. But as well as that, the chemoreceptors in the carotid bodies and the aortic bodies, primarily the carotid bodies, will detect oxygen lack, and that will also stimulate ventilatory effort. And that works fine in normal physiology. Now, if patients have got chronic bronchitis, for example, and the airways are chronically narrowed, they find it difficult to breathe out all of the carbon dioxide, and the concentration of carbon dioxide in their alveoli will increase. This means the concentrations of carbon dioxide in their blood will also increase. And over months and years of being chronically hypercarbic, or hypercapnic, having high levels of carbon dioxide in the blood, this will eventually overwhelm the carbon dioxide sensing cells in the medulla oblongata. And what this means is that they will no longer respond to increased levels of carbon dioxide as yours will. So if patients are chronic carbon dioxide retainers, if the levels of carbon dioxide in their blood increases, that will not increase their ventilatory effort. What this means is these patients are dependent on oxygen lack to stimulate their ventilatory effort. So they depend on oxygen lack. So the reason these patients breathe is not because the levels of carbon dioxide increase, but because the levels of oxygen drop. The levels of oxygen are detected by the aortic bodies and carotid bodies, sending nerve impulses up to the medulla oblongata to stimulate respiratory effort. Now, in some of these patients, not all of them, but in some of them, if you give them high concentrations of oxygen, then the concentrations of oxygen in the blood will increase because of your oxygen therapy. And of course that will reduce the hypoxic drive. The levels of oxygen in the blood will be increased. That will be detected by the aortic and carotid bodies, and that will be reflected in the nervous impulses going up to the medulla oblongata. The carotid bodies will report that there is plenty of oxygen in the blood, and that will reduce respiratory effort. These patients will ventilate less. And the trouble is, if they ventilate less, if they hypoventilate, yes, they've got enough oxygen because you're giving it to them, but because they're hypoventilating, that means they're not blowing off the carbon dioxide as normal, and that means the amount of carbon dioxide in their blood will start to increase beyond even normal levels for them. And some of that carbon dioxide will form carbonic acid. And we can always check if this is happening, because in many patients with chronic bronchitis this doesn't happen actually, but we can always check by doing blood gas analysis. And if the patients are retaining carbon dioxide, there's more carbonic acid in the blood, what's that going to do to the pH of the blood? Well, if there's more carbonic acid in the blood is going to become more acidic, so the pH will fall down into the acidotic range. And if the blood becomes sufficiently acidotic, this is called carbon dioxide narcosis. And these patients can become drowsier and drowsier as they become more acidotic, and eventually, if it's bad enough, in theory, they can virtually stop breathing and can die. So the rule of thumb in clinical practice has always been that patients with chronic bronchitis who are carbon dioxide retainers should only be given 24% oxygen as a rule of thumb. We can increase it beyond that once we know what the blood gas results are, And if we find that the patient is not going acidotic, then we can increase the amount of oxygen that we give them. Now, all what I've just told you is true, and it is in the British Thoracic Society guidelines. But in practice, I think more patients have suffered and died because of lack of oxygen than have died from carbon dioxide and narcosis. So really this shouldn't be used as a reason for not giving patients that need oxygen. If a patient needs oxygen, they have to have it. It's not some kind of option. Patients die of hypoxia. So give a patient the extra oxygen they need, but get in senior review, get the blood gases tested, and then we can titrate the oxygen therapy accordingly. Because no one, not even a chronic carbon dioxide retainer, can survive without oxygen. What actually happens with these patients if you looked after them, they'll be out in the community for a period of time, maybe with a bacterial exacerbation, an acute exacerbation of chronic bronchitis. And because they're hypoxic, because they're not breathing properly, they're not getting the oxygen in, that will be reported to the brain stem, and that will increase sympathetic activity, because sympathetic activity is the normal response to hypoxia. And then when they come into hospital and you give them some oxygen, because they're so tired, they tend to fall asleep. And they can fall asleep because you give them oxygen. That increases the amount of oxygen in the blood. That's reported from the aortic bodies and carotid bodies up to the medulla oblongata of the brain stem. And that reduces the sympathetic outflow. So there's less sympathetic activity. And so the fact that they've been out in the community for ages fighting hard to breathe with increased sympathetic activity, and once that sympathetic activity is gone, because you've taken it away by giving oxygen therapy, what these patients normally do is they fall asleep. So they need watched when they're asleep with oximetry and just general assessment of their respiratory status. Because when you're giving them oxygen, there is a possibility that the combination of the oxygen and the sleep are going to cause hypoventilation. And remember, it's not stopping breathing that's the problem. It's if you don't notice the patient has stopped breathing that there is a problem. Right, I think the last thing I'll say when we're talking about oxygen therapy is we'll talk about long-term oxygen therapy. And it's been known for a long time now that patients who've got chronic respiratory diseases do much better if they're on long-term oxygen therapy at home using oxygen enrichment devices to increase the amount of oxygen that they breathe in. And the higher the amounts of oxygen, for the more time that these patients can be given it, the better their prognosis will be. So let's think about what's happening here. Now, if there's reduced levels of oxygen in the lungs, so if the airways are blocked up and the oxygen can't get in, that's going to reduce the amount of oxygen in the alveoli. That makes sense. So you'll get relatively low levels of oxygen in the alveolar air. And that causes a reflex vasoconstriction of the pulmonary arterioles to that area. Now, in normal physiology, this mechanism makes perfect sense. Because if there is a reduced delivery of oxygen, gaseous oxygen to an area, there's no point sending a whole load of blood there to get oxygenated because there's no oxygen to pick up. So normally this means that the lungs can work at maximum efficiency and more blood will be sent to areas of the lung with more oxygen to pick up. But in chronic bronchitis, all of the alveoli have reduced amounts of oxygen. This means that the pulmonary arterial reflex vasoconstriction is going to be global. It's going to affect the entire lungs. So all of the alveolar arterioles, all of the pulmonary arterioles will vasoconstrict because of the hypoxia and because of the reduced levels of oxygen in the lungs. And of course, what this will do, because there's global vasoconstriction of the pulmonary arterioles, is this will increase pulmonary arterial blood pressure. Because remember, blood pressure is cardiac output multiplied by peripheral resistance. If we've got global vasoconstriction, then that is going to greatly increase peripheral resistance. So the reduced levels of oxygen in the alveoli cause the pulmonary arterial vasoconstriction, and that's going to cause pulmonary arterial hypertension. Now, if the blood pressure in the pulmonary artery is high, if there's a pulmonary arterial hypertension, what's that going to do to right ventricular workload? Well, because the pressure is higher, the right ventricle has to pump harder to discharge blood into the pulmonary artery. And over time, that's going to cause a right ventricular failure. The increased ventricular workload will firstly cause ventricular hypertrophy, and that will go on to cause right ventricular failure. So there'll be a right ventricular failure caused by lung disease. This used to be called cor pulmonale. We now call it pulmonary heart disease. And because the right ventricle is not working properly, that means that the blood from the inferior and superior vena cava is going to get backlogged. It's not going to be able to go through the right atrium because it can't get into the right ventricle. So you're going to get systemic venous hypertension as a result of the right ventricular failure. And because there's systemic venous hypertension, that's going to increase the pressure in the systemic capillaries, and that means that less tissue fluid is going to be reabsorbed. So there is going to be systemic edema. So if these patients of chronic bronchitis are hypoxic, hypoxemic. If they're hypoxemic, they're going to be blue because of the cyanosis. And if they've got right ventricular failure, they're going to have systemic edema, so they're going to be bloated. That's why these patients are sometimes called blue bloaters or blue and bloated. So what to do about this? What to do about this is to give long-term oxygen therapy at home, often via a nasal cannula. And we increase the amount of oxygen in these patients' alveoli. If we increase the amount of oxygen in the alveoli, that will allow the pulmonary arterioles to vasodilate. If the pulmonary arterioles vasodilate, that will reduce pulmonary arterial pressure. If we reduce pulmonary arterial pressure, we will improve right ventricular function because we reduce right ventricular workload. If we improve right ventricular function, we're not going to get the systemic edema. So giving the long-term oxygen therapy at home significantly improves these patients' prognosis because it's going to prevent the lung disease causing right-sided heart disease. Heart disease.